For paucity of time, we will go to the next session.
Thank you.
Thanks for showing those excellent cases, very challenging cases. And we'll go to the debate on left main bifurcation, angioplasty versus surgery. And this is an old debate, and it continues to enthuse all of us. The speaker in this is Ramesh Dagubati from New York. He's going to speak in favor of PCI.
Thank you very much, my dear friends and audience who will be here. Thanks to Dr. Srinivas for inviting me, and the chairperson, Dr. Sharath, and Sridhar, and Srinivas. Great pleasure being here. So, I'm going to be debating against Evelio Rodriguez, who's Evelio. He is the chief of cardiac surgeon at St. Thomas in Nashville, Tennessee. In 2007, he has done more than about 1,200 open hearts and nearly 300 to 400 TAVRs, 100 mitral clips, and many more accolades that my entire time will be completed by just talking about him. Here you can see Evelio is with a beautiful family. The wife is a breast surgeon, and 3 young kids entering into college and high schools. But Evelio is probably hurting right now. He is trying to see, with all the presentations from Dr. Hiremath and Dr. Ajay Kirtane, that how is he going to make his point and say that surgery is going to be superior to PCI. So Gruntzick's third PTCA was actually with the left main. So he did, this is a nice left main patient where he just ballooned it in September 1977, and the first angiogram later was November 11th, it was repeated, and showed severe stenosis of the left main coronary artery. However, the patient expired suddenly about 6 months after this procedure, 4 months after this procedure, and hence actually Gruntzick shied away from recommending left main PTCAs. In the next few minutes, we'll talk about all these things. And let's look at a pathology of, so let me start with this. This is a 90-year-old Chinese woman with non-ST elevation MI, ST elevations in AVR, diffuse ST depressions in other leads, and troponin was elevated at 45. So you can see that actually that significant left main bifurcation involving the ostial LAD and ostial circumflex. RCA is also definitely a heavily calcified vessel with the 90% ostial left main disease, ostial RCA disease, as well as LV systolic dysfunction with an EF of about 30-35%. So why do we refer these patients for left main for bypass surgery? The pathology is slightly different. The left main has more elastic tissues, and elastic tissues definitely cause more restenosis. And also, as you can see, the plaque formation is more at the low shear stress areas, which are the ostial LAD and ostial circumflex on the lateral aspects of the vessels. But that said, in syntax, based on PCI versus CABG, PCI in the yellow, the syntax score of less than 32 did quite well with PCI. Even less than 22, obviously, they did much better. But patients with a 33 or higher syntax score, the PCI definitely had a higher chance of major adverse cardiac events in the left main subset of patients at 3 years. And we have seen this slide from Dr. Kirtane showing that at 3 years in Excel study, death, stroke, or MI was similar between PCI and bypass surgery. What are we concerning about left main disease? It's the hard endpoints such as stroke or death, which are similar in the Excel study. Death and stroke are similar. Myocardial infarction is debatable based on how you define MI. As you know, it is more than 10 times upper limit of normal in Excel study that lower MI rates were seen with PCI as compared to bypass surgery. But all the other factors which are in favor of PCI are actually soft endpoints, but still that is a concern for many of the healthcare providers in the United States, that they look at the transfusion rates is considered as a complication if they give more than 2 units during bypass surgery. So obviously PCI has done extremely well, both in Excel as well as even in the Noble study that we have seen from Dr. Kirtane. But then let's look at the meta-analysis of nearly 11,500 randomized patients, of which 4,400 are with left main disease. All-cause mortality between PCI and bypass surgery is similar. And if you look at other diabetic versus non-diabetic, right now we always say that diabetic people and high syntax score should get bypass surgery. But if you look at this meta-analysis, diabetes versus no diabetes or even syntax score did not really make any impact on outcomes in favor of bypass surgery. So PCI and bypass surgery are similar. Henceforth, the recommendations in Europe have already given the left main PCI as class 1B for low syntax score, less than 22, and 2AB for less than 32 syntax score. In US, we are still lagging behind a little bit. It is still 2A for low syntax score PCI of left main patients. So when we decide whether stents or surgery for left main, it has to have several factors, clinical factors, anatomical factors, and the patient's factors. What is the patient's wishes? You have to think about that. The clinical factors here, as you can see, if somebody has a low ejection fraction, long-standing diabetes, need for concomitant cardiac surgery such as a valve surgery, and high bleeding risk, unable to comply with the DAPT, then probably you should consider for bypass surgery. And obviously, anatomical factors, left main and several chronic total occlusions, increasing the syntax score of more than 32 in such patients that you should consider bypass surgery as well. Otherwise, majority of these patients should be served well with PCI alone. So in just my opinion, you say favoring PCI less than syntax score of less than 32. And obviously, as Dr. Hiremath has shown, some of them presented with MI. Nobody is going to touch the patient. According to guidelines, it is class 1 recommendation to go for bypass surgery, even in the midst of an acute MI. I'm yet to find a surgeon who has the guts to take a patient during infarction for a bypass surgery. And obviously, mobilizing an operating room takes nearly about 2 to 3 hours. So anatomy, if it is suitable for PCI, definitely you should consider PCI. And as we said, this is an old dictum. Still, it is good in majority of the patients, diabetes, systolic dysfunction, multi-vessel involvement with CTOs, which increases the syntax score to more than 32. For left main, ostial and mid shaft, I don't think this is a point where we can say heart team, but I don't know whether the heart team is really required in this patient. Unless if the patient comes back with the restenosis, probably it is okay to discuss with heart team. But ostial and mid shaft, I actually think direct stenting is much easier and treated as single vessel. When it comes to bifurcation disease, probably that's where you can talk about heart team and think about what type of 2 stenting is better. As we have seen today, mini crush or provisional stent strategy, both of them have been applied in both at Apollo as well as at SGPGI. So think about all the factors, whether angle of the side branch, the length of the side branch lesion, which favors a 2 stent techniques or a single stent technique. And in DK crush, which is what we prefer most of us, 12-month target lesion failure is much better with the DK crush rather than with the provisional stent strategy. But that said, in this trial, they looked at the DK crush patients were having the length of the side branch lesion was more than 10 millimeters. And in DK crush 3, about 3-year major adverse cardiac events in unprotected left main and among 863 patients, DK did much better than culotte stenting. So I think getting a double casing crush technique is much better. So definition is another study from the same group, Dr. Chen, defining the left main disease as or a side branch bifurcation disease into simple versus complex. Simple basically means that stenosis is less than 70%, length of the lesion in the side branch is less than 10 millimeters, and the angulation is all not steep angulation. Whereas if they are much worse, more than 70% stenosis, length of the side branch is more than 10 millimeters, obviously it makes it more complex, and in complex lesions, DK crush did much better than actually provisional stent strategy. In true bifurcations, obviously, you have to elective implantation of 2 stents based on the definition criteria is recommended. So which stenting strategy, I think it all depends upon the angulation and the length of the lesions, but you have to use IVUS in majority of the patients, as been shown in Excel. 77% of the patients used IVUS, and using IVUS definitely has a major impact on reducing mortality by about 7% absolute risk reduction in mortality. Here is our 90-year-old Chinese patient who was referred to surgery. Surgeons actually referred back to PCI, and the PCI was easily performed without any problems. So PCI has the same class of recommendation as evidence of a CABG in unprotected left main with syntax score less than 22. With evidence coming from Excel and multi-center registries, it should also apply for syntax score less than 32. In unprotected left main with the syntax score more than 32, that implies also the presence of extended CAD. Still, CABG, when feasible, is recommended, but here is where the heart team plays a greater role. These two are very different procedures. I think we have to make sure that bypass surgery and PCI should not be competing against each other, but should be complementary. Thank you very much.
May I now request Dr. Avelio to give his talk supporting CABG for LM stenosis.
Is this a laser? Okay. Good morning. Well, first of all, thank you very much for inviting me. This is my first trip to India, so I'm excited about being here. Thank you to Ramesh for inviting me, and I feel a little lonely here as an only heart surgeon, I think. So let's see what I can do. So what I'm going to try to go over is left main disease and make the case for heart surgery or for CABG, and we'll see how we do this. These are my disclosures. This is what I'm going to try to do, go over the history, review the guidelines, talk a little bit about cost effectiveness, and tell you what I think the future is going to be. So this is the history, and basically, as we know, bypass surgery in the 80s kind of became the standard for left main disease. As Ramesh discussed, the third stent was put in the left main. And then after that, we have a series of trials looking at the benefit of bypass surgery versus medical therapy. And there's no doubt that on patients with triple vessel disease, that is the best case. And it also for left main stenosis or left main equivalent. And then as it has been mentioned, we have several trials looking at left main disease versus CABG, pre-combat, syntax, novel, Excel. And I'll go a little bit over them, including Le Mans. As it has been discussed, the left main is a little bit different for several reasons, but the disease most commonly involves the bifurcation. So when we talk about left main disease, and you saw from both Excel and Noble, around 80-something, 90% of the cases have left main, including bifurcation. So most of this are going to be more complex cases. And from the cases what you saw this morning, this is not something that a interventional cardiologist is doing a few cases a year. It's something that should be tackled. And at the same time, surgeons, for the most part, this is one of the easier cases that we would do. And the other problem is that because of the location of this disease, there is a lot of myocardium at risk. So obviously stent thrombosis for most of these patients would be lethal. What are the options we have for this type of disease? We can put a mammary, we can put a vein graft, we can put stents. I would argue that the Lima is the best graft, and you can see the reason why. When we use the Lima, you end up with, this is at 12 years versus a vein graft. And obviously the stents, depending on which stent we have, which series we change. And we always say, well, the prior study was with an all stent, we're going to get a new stent. So the way I look at this, so we have two people here. We have David and Goliath. Here's a stent, so I look at this as the David, and the Goliath is the big surgeon with a big incision with a bypass, which looks something like this. There's Ramesh here, this is me. And most of you say, well, the history says that David beats Goliath, but sometimes history doesn't repeat itself. Sometimes the reality is Goliath may be bigger and better, and maybe David just got lucky the first time. So let's see. This is why CABG is better. CABG is better because PCI only stents that lesion, the proximal lesion. There is disease that forms later, and especially in the LAD, you have in the left main, you have a lot of area of myocardium at risk. So what are the guidelines? So these are the guidelines that they've been shown multiple times today. No matter which way you look at it, CABG is the only one that has a 1B indication. There's a reason for that, and that includes the recent studies. In the European guidelines, they changed to a 1B to the low syntax, but even though, as Ramesh showed in the diabetic patients and others, there was no difference, still no one is inclined to change the guidelines. Now, they may change in the future, but at this point, CABG is still the indication for these patients. This is early data on the 2005 New England Journal of Medicine looking at multi-vessel disease. And what I want to stress here is that when you have 3-vessel disease or left main equivalent, surgery always wins over PCI and stenting. So what are the trials that we have comparing left main disease? These are the series of trials: Le Mans, Pre-Combat, Syntax, Excel. So let's go over that. This is Le Mans early trial, 10-year, only 52 patients and 53 on each side. And basically the conclusion was based on 33 PCI patients, 32 CABG patients. Really a very small sample size to make any conclusions. In addition, the LIMA was only used in 73% of the patients. So really you're not comparing what we usually do. In these patients, 99% of them will have a memory. When you look at syntax, it's kind of all over the place, and Ramesh showed this, where basically if you have low syntax, the PCI is favor, but overall in the trial, CABG is favor no matter which way you look at it. When you look at 5 years, and we talk about repeat revascularization, and other panel members have made some comments about, well, repeat revascularization is not a big deal, and the patient would rather have a re-PCI versus having a sternotomy. Well, the reality is that when you look at least on syntax at 5 years, repeat revascularization is an independent predictor of death, stroke, and myocardial infarction. So again, it's not just that they're just going to go and get another PCI and another stent, it's that if you look at that patient subgroup, they have a higher mortality. These are the syntax scores again, and in the high patient population, in the high syntax, there's no doubt that surgery is better, and that's why we had that guideline. So what are the issues with these early studies when we take syntax, Le Mans, and Pre-Combat is that using syntax and taking the left main subgroup as an evaluator is not valid because the study was not powered for that. There were early generation stents, and the follow-up on a lot of these early trials was too short to really make a point whether or not it was good for CABG. This slide has been shown, so I'll just skip it. These are the 2 trials. And the primary endpoint of death, stroke, and MI at 3 years was not different. But however, I think this is what I want to make a point is that when you look at 3 years, those curves, they start shifting. And survival starts showing better for CABG. And this is something you would expect. We really don't care about 30 days. We really want to know what happens to these patients at long term. So the jury's still out, and I think it will be exciting to see what happens in the next few years with Excel patients. When you look at this, and Ramesh showed this, you're basically looking at MI being the main reason for an elevated number of MACE in the CABG group at 30 days. And this is just because of that measurement that we're measuring for MI. And in the same way, when you look at 30 to 3 years, it is again this revascularization that is driving the higher MACE. But at the end, when you look at 3 years, those curves they start shifting, and survival appears to be better. So again, when we look at any therapy, and this is a picture of my friend Ramesh when he finished medical school, and if the question is this doctor going to be successful, we really don't care what happened to him at 30 days. We really want to know what happens to him for the rest of his career. So I'll show you where he is now, but at this point, we really couldn't tell anything. And success is more of a marathon than a sprint. So let's look at more of this marathon. So when you start looking at 3 years, and now you separate these patients between male and female, what Excel showed was that for females that have PCI, their mortality was in the 19%, and there was no statistically significant difference. So again, PCI of the left main in females appears to be worse. And my question to Ramesh is, would you do left main PCI on your mom or your wife? I guess if you don't like them, but I think based on this, it's something that we have to keep an eye on it. Again, when you look at Noble now, so we move from Excel to Noble, yes, at 5 years, and this had to include the repeat revascularization, but again, this trial showed no benefit of the PCI or no, it did not meet the endpoint. And this is why. The MAZE, it was 29% versus 19. When you look at the updated meta-analysis, and now what you're taking is taking all these patients and putting them in a blender and getting them out. But no matter which way you look, for MI, CABG is favor. For death, CABG is somewhat favor, except for, and obviously for repeat revascularization, CABG is favor. Stroke is the only one that had the mixed results. But I think for most of us, even the surgeons would agree that PCI should be associated with less stroke than surgery. When you look at this 4,686 patients, and you look at 30 days, PCI appears to be better. However, when you look at long term, then all of a sudden, bypass surgery appears to be better. And again, I want to remind everyone that success is a marathon, it's not a sprint. Syntax at 5 years, Ramesh showed this, and basically the conclusions of the study was that all patients with complex multivessel coronary should be evaluated by the heart team. And I think that that's something that Ramesh has stressed. So when we look at the heart team, this is 3 of us. This is myself, Ramesh here. He was in Nashville visiting, giving a talk. This is another heart surgeon. And the question is, this heart team approach was that night to go out, but when we're taking care of patients, the question is how do we do it, and are we really friends or not? This is a study from the New York State looking at what happens to patients when they go to the cath lab. So when they go to the cath lab and they get seen by you guys, and you guys do the cath, and you look at the disease, what happens to them? So of 16,000 patients that were cath, 10,000 patients had disease. 59% of those patients had an indication for PCI, and then of which 94% of them had a PCI, 2% had a CABG. 13% of them had an indication for CABG, and basically only 53% of those people had a CABG, 34 had a PCI. And of the 17 patients that could have either or, 93% had PCI and 5% had CABG. So again, even though we talk about this heart team, the reality is most patients are not being evaluated by the heart team. And my question is, and the summary was that the final recommendations are usually frequently given by the cardiologist without having really an informed consent. My question is, are we really friends or not? And who is the one who's talking to these patients? When we talk about cost effectiveness, 2 studies, basically taking data from Freedom. There's also taking data from Syntax, and then I'll show you one from a Dutch study. But both of them show that long-term, there is a cost benefit for the CABG patients. In part is because of the lack for need for repeat revascularization. So this is something we have to keep in mind as we do new trials and as we talk about these patients. So in conclusion, left main stenting may be considered in the low Syntax scores, especially if they are significantly high risk for CABG due to age, comorbidities, or frailty. Repeat revascularization is an independent predictor of death, stroke, and myocardial infarction that was based on Syntax trial, and a heart team approach I think is crucial. I agree with him. So when we look at someone like this, maybe we're looking at a patient with low syntax with high risk, maybe a patient like this patient may be better for PCI and stenting. Now, a patient like this may be better with surgery, and I'll be happy to do his surgery if he agrees. So again, going back to this, why is it that we have David at Goliath? And the reason that surgery wins most of the time is because of this memory. It's because of the Lima to the LAD. So what I would propose is that I think that in the future, we should consider this a little bit more. So if we can give you the best that we can give as surgeons of a Lima to the LAD through a small incision without putting the patient on the pump with minimal risk for stroke, and then you can go and do a stent, which now is protected, I think the patients are going to win. This has not really gained a lot of popularity, and it's in part because of a lack of both the heart team approach to these patients and try to promote this. So like I said, success is not a marathon, success is a marathon, not a sprint. Remember I showed you this picture? This is now Ramesh with his son in Iceland, and they're in a little spring tub looking at the mountains. So obviously his life has been a true success, as you would expect from a marathon that he's run. And it's been a pleasure being here today. Thank you very much.
Thank you, Dr. Avelio. As Ramesh is coming onto the stage for giving the rebuttal, I'll request Soumitra, would you like to comment on this debate? Soumitra for a brief comment, and then Shivkumar and any other panelists.
Now it's finally down to David versus Goliath, and let's see who is the David. And so I asked for Dr. Daggubati. Dr. David, would you give your first rebuttal?
Ramesh, the time is very short. We have overstepped the time. So quickly give a 1-minute rebuttal. Yep.
So Avelio has done an excellent job in talking about PCI versus bypass surgery, but his last conclusion slide said actually PCI should be recommended for all the patients with the syntax score less than 32. So in my rebuttal, I would say when you should not consider PCI is what I would say, and inability to, can I have the slides please? So inability to take a dual antiplatelet therapy, diffuse disease under unprotected side branches, absent access in somebody who does not have any access, inability to completely revascularize, patient's preference, and chronic kidney disease. I don't know which patient will prefer bypass surgery if you give that as the only option, but how are we able to achieve excellent results is actually by IVUS guidance in Excel study, which was used in 77% of the patients. But if you look at the general population in PCI, we only use IVUS in about 10 to 20 of the percent of patients. So use always IVUS, and definitely complete revascularization has a definite impact on mortality. And if you see the low residual syntax score has or complete revascularization has the lowest mortality as compared to high residual syntax score. Improved outcomes are seen with the second generation stents or third generation stents that we have as compared to even the syntax, which has used actually a tax stent that's not even available on the market. And at the end, we should send Avelio happily, because I don't think that PCI or bypass surgery, as I was saying, that it is one door or the other. It is a path that you have to take sometimes. You might take a left turn and then come back to the same. The roads do meet at the end, and probably hybrid revascularization is not a bad thought after all. Thank you very much.
Okay, now Dr. Avelio for a very brief comment.
I'm sorry?
Very brief comment. With that,
Yeah, it will be very brief. I agree with Ramesh. I mean, I think at the end, there is a patient population that would benefit from a PCI and stenting, the low-risk syntax. I think hybrid revascularization should be more used. We always talk about what does the patient want. The patient always going to want the least invasive thing, but that doesn't mean that it makes it right. I think we as physicians have to make sure that we give them the option that we think is best for them based on the data that we have, not on what we think. And we should use that data, and right now that data is very clear on where PCI and stenting stands versus surgery, and I think it has been made clear here. Thank you very much.
okay.
Thank you very much.
Thank you. I request Shivkumar to conclude the session.
Thank you so much. It was really a lively debate between CABG and PCI. I think this debate will continue for a long time but I personally feel, I think the hybrid is the future. probably the lima to LAD and then the stenting to the other vessels should be the future. Thank you.
The next session, left hand practicals, a rapid fire walk with me. I request Dr. Sharachandra to speak on left hand stenting with SKS technique.
Thank you, Dr. Sridhar. Could somebody put these slides on?
I think if every presenter finishes very quickly, the audience can comment. So these are all cases. I think you can exchange views also. But if you take more time, there will not be any time for exchange of ideas because we have very limited time. Meanwhile, anyone wants to comment on SKS technique? Many times like a SKS technique, so I use for emergency purpose. So like a SKS technique, particularly if the main vessel is very large, both side branches are equal size. SKS particularly if the patient has acute MI, like a distal left main, tight occlusion, where you don't have time, immediately take 7 French and simultaneously pass 2 eyes. And if you are ready, simultaneously you can implant stent quickly. So when patient is hemodynamically compromised, where you don't have enough time, then immediately you can go with the only problem with the SKS technique, suppose if the patient develops re-stent, yeah, you can proceed.
Yep. Thanks, Sridhar and Srinivas Kumar for giving me this opportunity. I'm going to briefly show you a couple of cases of simultaneous kissing stents in LM bifurcation and quickly tell you what the data shows. This is a rather complex case of a, you can say Medina 111, and in fact there is another lesion little down in the LAD, and the same thing is shown in RAO caudal view with disease rather complex, and we thought that this was a case suitable for SKS, and you can see here that both the vessels are wide and a thorough dilatation of the bed was done, and there's a reasonably good dilatation of the LM lesion, and you can see both the stents in LM going into LAD and LCX, and an attempt was made to position them very precisely with both markers exactly next to each other, and you can see that the dilatation is done initially. Both the stents are dilated at the same time at a relatively low pressure of about 10 atmospheres. Then each stent is dilated at about 18 atmospheres, and then both the stents are dilated once again simultaneously at about 14 atmospheres. This is the usual protocol I follow, and whenever we do SKS, and here you can see that the result is pretty good, and later we put another stent a little down in the LAD to cover that small area. Yeah, that's the final result, and the patient did pretty well and is still on follow-up. And you can see here, this is the next case. Yeah, this is a relatively simpler case in the sense that the lesion is involving both the ostia, and it is kind of suitable, and the LM is very, very big, and it is kind of suitable for V kind of stenting, and that's what we did in this case. And you can see here that both the LAD and LCX are about equal size, and we have positioned the stents in a V shape, and there is still a minimal dilatation which was taken care of by another dilatation, and yep. Yeah, this is another case, and okay. This is a relatively sicker patient. In fact, he presented with acute unstable angina, and he had hypotension, marked STT changes, and the family was a very worried lot, and it was just before a holiday, and so we had no choice but to do a quick angioplasty for this patient, and you can see that this patient, the lesion is involving LM bifurcation and ostia of both the LAD and LCX. Once again, a Medina 111. And yeah, of course, the rest of the procedure is simple. The angle between the LAD and LCX is relatively less and is rather suitable for an SKS. And you can see here, both of the stents are placed there, and result you can quickly see that it's a very eye-pleasing result. And in fact, the patient is on follow-up and is doing very well. You can see this is the result, and this is the, yep. This is the final result of SKS for this patient. Now, this is, I have done 4 cases of LM bifurcation with SKS, and you can see here the age ranged from 42 years to 52 years, 69 years. One was a female patient who was in the 70s. And the first case I did was in November 2015, and all of them did very well. Unfortunately, I could not do any of these cases follow-up angiography, but clinically all of them did very well. Now, one of the largest experiences on SKS in LMCA is by Gunn et al. It was published in Euro Intervention 2014, and that was 140 consecutive patients. Patients were treated between 2004 to 2008. They used the first generation stent, the Taxus stent. The success was 100%. Again, here, most of the patients were acute coronary syndrome patients, and the in-hospital mortality was 6.4%, and 1-year mortality was 11.5%, but for elective cases, it was 2.3%. 2-year mortality was 13%. TLR was 4.1% at 1 year and 5.8% at 2 years. The same group of authors published a data more recently in November 2017 of 118 patients, 89 patients. A majority again were emergency procedures, and they looked at the restenosis rates, and they based their selection for the patient to look for restenosis was the clinical symptoms, and you can see that recurrence rate was 7.5% for the first generation stents and 4.4% for second generation stents. Initially, they also used Taxus, and later they shifted to Zyne stent. The repeat PCI was done in 16 patients, and the site of restenosis in these SKs for LM was LM to LAD in 10 patients and LM to LCX in 16, and both in 9 patients. What are the important points to remember when you do SKs for patients of LMCA stenosis? The vessel size is very important. The LM should be a large LM. If it is a small LM, then that's not a case. In fact, from the Excel data also, if you see, the small sized LM is generally not a good case for PCI. The vessel size, if it is 3.5 to 4 millimeter size, that's a good case. Avoid SKS in case the angle between LAD and LCX is more than 70 degrees. Obviously, these cases should have a Medina 111. That's where the SKS does best and where it is indicated. And the 2 branches, the LAD and LCX, should be of the nearly equal size so that one dominant LAD or an LCX will not compress the other vessel. And the guiding catheter obviously should be at least 7 French. 6 French guiding catheter would not usually take 2 stents at a time. The wires, there is nothing very specific. Good predilatation is advised, and stents placement should be very, very precise with the proximal markers just adjacent to each other, which is checked in more than one view, so that a little proximal portion of one stent will not compress the other stent. These are some of the important points. Thank you very much.
Thank you, Dr. Sharachandra.
I'll make two comments on this one. This is a very good technique, but there are some pitfalls. First of all, we should not lose the wire axis. If you lose the wire axis, difficult to cross. Second one, it's like two barrels in the left main. Second one, don't deeply push the catheter into the left main. Sometimes it will distort the anatomy and very difficult to. The stents overlap and that will be difficult. So these are two important things in this one.
You know, I agree. This is not a chest thumping technique like, DK crush or crush technique. But where the patient is relatively sick, where you do not want to use too much of contrast, you don't have too much time, and the anatomy is suitable. That is, of course, very important. A big LM with two big branches, nearly equal size, angle less than 70. That's a case for SKS. And the SKS data at least shows that the follow-up of these patients is as good as other techniques.
Only thing, when you do the part, don't pull the balloon beyond the stent proximally. Suppose the proximal dissection takes place, very difficult to put proximal stent. Only thing is you have to crush. You put the stent into the LAD or L6 and whichever is bigger and crush it. Then you have to do the kissing. That's the main problem.
Well, that's making it more complicated. The other thing many people advise is, if the wire axis is still there and dissection has occurred, put two more stents into both of them and then do SKS again. I think time does not permit you to go for further discussion. Yep.